Hi friends, in this video we shall be discussing regarding burn. So the basic management of your burn follows the same principles as we discussed of the advanced trauma life support guidelines, which includes your A, B, C, D, E, that is A for airway, B for breathing, C for circulation, D for disability assessment, and E for exposure. In addition, over here in burns, F is also important, that is your fluid resuscitation. So let's discuss some important concepts which are specific to your burn management. Now, the first question that we are often asked is, what are your major determinants of your outcome of burn? So they include your percentage surface area involved, the depth of burn, the presence of inhalation injury, and age and comorbidities of the patient. Then, what are your criteria for acute admission to a burn unit? So we have this table from your Bailey and Love. When we have a suspected airway or inhalation injury, any burn that is going to require your fluid resuscitation, any burn likely to require surgery, patients with burn of any significance to hand, face, feet, or perineum, patients whose psychiatric or social background makes it inadvisable to send them home, right? Any suspicious of your non-accidental injury, then any burn in patient at extremes of age, any burn that is associated with your potentially serious sequel including high tension electrical burns and concentrated hydrofluoric acid burns. So these are your criteria when you would admit the patient to a burn unit. Now, the next important concept is regarding your potentially burned airway. How would you know that? So these are your clinical clues that is going to help you to identify your potentially burned airway, which includes your history of being trapped in the presence of smoke or hot gases, burns on the palate or nasal mucosa or loss of hair in the nose, deep burn wound around the mouth or neck, and hoarseness or change in your voice, right? Now the next is regarding your burn size assessment. So we use the percentage body surface area, and the standard for formatting and assessing in burn unit is your Lund and Browder chart. So this is your Lund and Browder chart where your relative percentage is given as per your body surface area involved. Now, in your pre-hospital and emergency setting, for your first hand approximation, we use this Wallace rule of 9, right? Please remember, it is your first approximation only. So if you see over here, you have your head which is given 9%, 4.5 anterior, 4.5 posterior. Then you have your torso trauma which is given 18% in your anterior part and 18% in your posterior part, making it a total of 36%. Then you have your one upper limb which is given a total of 9%, 4.5 anterior, 4.5 posterior. Then you have your lower limb which is given 18%, 9% anterior and a 9% posterior, and then you have your 1% involving your external genitalia. So please remember that you might be getting a question of a clinical based scenarios where they would be mentioning you regarding the area involved, from where you need to calculate the percentage of your total body surface area and calculate your fluid requirements. Now regarding your burn size in children, it is again done with the help of modified Lund and Browder chart for children. At birth, your head is around 18% and lower limb is your 13.5%. Now for each year, 1% is subtracted from the head and 0.5% is added to the lower limb until the age of 10 years. Right. So please remember this assessment of burn size in your children. Then we have the assessment of depth of burn. So there could be some causes of burn which basically help us to estimate the depth. For example, a scald, that is a superficial but with deep dermal patches in the absence of good first aid. It will be deep in a young infant or elderly. Fat burn, it would be deep dermal to your full thickness. Then flame burn, it would be mixed deep dermal and full thickness burn. Then you have your alkali burns and including cement, which are usually deep dermal or full thickness. Acid burns, your weak concentrations are usually your superficial, whereas your strong concentrations are your deep dermal burn. And your electrical contact burn are your full thickness burn. So on estimating, if you are given the cause of burn, it will help you to understand the probable depth of burn. Now regarding your various depths of burn, so we have this new diagram that is included in your Bailey and Love recent edition. So just trying to understand this table is going to give us an assessment of regarding the various types of depth of burn. So the first step would be looking at the burn. Now, is the epidermal integrity intact? So this is known as the Nikolsky sign. Now, if it is answer is yes, then it is your epidermal burn. Now, if the answer is no, then we run a gloved finger over the burn and check if it is slippery. If it is slippery, then we check the type of blister. Now, if the blister is your thin walled or popped, then it is a superficial dermal burn, which includes your blanching with pressure, very painful and very oozy. Right. Now, if the blister is thick walled, then it is a mid dermal burn, which is some mottling, blanching, sluggish, darker red base and some anesthesia, and these are less oozy. Whereas if it is not slippery, and then we check the burn color. Now, if the burn color is red, then it is a deep dermal, that is your decreased sensation, absent or reduced feeling after blanching, fixed mottling and little or no ooze. Now, if the burn color is white, then you have your full thickness burn, which includes your anesthesia, no refilling after blanching, maybe amber or translucent with visible black vessel, waxy, hairs fall out easily and dry. So, if we follow this particular table, we will know the characteristics also of the various types of burn and also help us to classify the epidermal, superficial dermal, deep dermal and your full thickness burn. Right. Now, moving to the next important concept is regarding the zones of burn, which was given by your Jackson, right. So, we have 3 zones of burn. So, you can see the first is your zone of coagulation. So, this is what your irreversibly damaged area. Then we have your zone of stasis. Now, zone of stasis is the point where your tissue perfusion is decreased, and then we have your zone of hyperemia over here where your perfusion is increased. So, please remember this regarding your zones of burn. Now, next important point or concept in your burn is regarding your fluid resuscitation. So, any adult with more than 15% of total body surface area and children more than 10% of total body surface area would require your fluid resuscitation. Crystalloids are preferred over colloids in the initial hours of your burn management, and in crystalloids we usually prefer Ringer lactate because it contains your potassium, which is important as in burn there is a lot of potassium loss. Now, how do we calculate the fluid requirement? So, we have this formula of Parkland. Now, again there is a controversy over here, as your Bailey and Love still mentions 4 ml per kg per body surface area. However, this is from your ATLS guideline and we shall stick to it. Right. So, this is your Parkland formula for adults and older children, that is 2 ml lingeractate into kg, that is the weight of the body into the total body surface area involved. Now, in case of children less than 14 years old, we have your 3 ml lingeractate into kg into body surface area. Now, whereas infants and young children, we have the same plus a sugar containing solution at a maintenance rate. Right. So, this is important that in infants and young children, that is weighing less than 30 kg, we need to add a maintenance fluid also. Now, in case of electrical energy injury, be it in any age. So, over here we have your traditional Parkland formula, which is your 4 ml into kg into total body surface area. So, please remember that the fluid loss is maximum in your first 8 hours and slows down by 24 to 36 hours. And regarding your maintenance fluid, so we have this formula: 100 ml per kg for 24 hours for first 10 kg, 50 ml per kg for next 10 kg and 20 ml per kg for 24 hours for each kg over your 20 kg. So, in your Parkland formula, please remember your first half of the fluid is given in your first 8 hours and then the remaining half is given over the next 16 hours. Now, regarding your colloid, now why do we use colloids and which is the most commonly used colloid? Now, this is your albumin. Now, when is it used? It is used after your first 12 hours. Now, the formula for calculating your colloid is your Muir-Barclay formula, right. So, it is the fluid in your first 36 hours. Now, how is it calculated? Total body surface area into weight into 0.5%, which is equivalent to 1 portion. So, 6 portions are given over 36 hours, 1 infusion 4 hourly for your next 12 hours and 1 infusion 6 hourly for 12 hours, and then you have your 1 infusion 12 hourly, right. So this is with respect to your colloids and your Parkland formula, right. Now the next important concept is regarding the monitoring. So the key is your urine output. Please remember, the key to monitoring in your burn is your urine output, which is 0.5 to 1 ml per kg per body weight per hour. Now regarding the treatment of burn wound, which includes your group A, that is the superficial dermal partial thickness wound. So the main goals over here is to prevent the wound from becoming infected, use of appropriate dressing, managing pain, and preventing the progression to your deeper burns. Then you have your group B, where which is your usually a full thickness burn, where your escherectomy may be required. Now this is a very important concept, and again the key features can be studied from this table which I have taken from your Bailey and Love. So in upper limb, it is mid-axial and it should be anterior to the elbow to avoid the ulnar nerve. In hand, it should be midline in digits. Release the muscle compartments of if tight, and it is best done in your operation theatre. Then your lower limb, it again should be mid-axial. It should be posterior to ankle to avoid your injury to long saphenous vein, and anterior to head of fibula to avoid injury to your common peroneal nerve. So please be very careful over here with the directions. They would usually change your directions, like they could put it posterior to head of fibula. No, you need to do it anterior to the head of the fibula to avoid the injury to your common peroneal nerve. Then we have your chest, which is down the chest, lateral to the nipples, across the chest, below the clavicle, and across the chest at the level of your xiphisternum. Then we have here some general rules which include that extend the wound beyond deep burn, diathermy, and any significant bleeding vessels, and apply your hemostatic dressing and elevate the limb post-operatively, right. So these are your few important concepts from your escherectomy. So please do remember them as questions are being framed from this particular segment. Now regarding your early burn incision, that includes your removal of eschar, reducing the bacterial load. Right. Then the majority of the surgery is done prior to your substantial lung injury sets and effective use of vasoconstrictive fluids. Then you have your delayed reconstruction. So the eyelids treatment should be done before the exposure keratitis develop. Now transposition flap and your Z-plasties may be used. Pharmacological treatment of itching should be done, and your full thickness graft for your large areas may be needed, and hypertrophy treatment with your pressure garments would be needed. Now the mainstay of your burn wound repair is your split skin autograft. And now regarding the nutrition in the burn, so adults with more than 15% and child with more than 10% of body surface area would require your greater nutrition requirements, and any burn with more than 20% total body surface area would need a nasogastric or your nasojejunal tube to start the feeding within 6 hours, right. So these are important one-liner questions that are asked to you in your exam from your burn. Now a little bit about your electrical injuries. So I have just included this table from which most frequently your questions are formed. So this low voltage injuries cause small and localized deep burns. Then they can cause cardiac arrest through the pacing interruption without any significant direct myocardial damage. Now this high voltage injuries causes damage by flash and by conduction, which is your internal burn. The myocardium may be directly damaged without pacing interruption, and the limbs may need fasciotomies or amputation, and we need to look for acidosis and myoglobinuria, which can eventually lead to your renal failure. And a few points regarding your frostbite. This mainly affects the peripheries in the cold climate. Now the initial treatment is your rapid rewarming in a bath at your 40° Celsius. Now it causes your delayed microvascular damage, and you need to go for a conservative treatment until you have a clear-cut demarcation of level of injury, following which a surgery may be required.